I'm a consultant pediatrician. I'm based in South Wales at the moment, and this evening I'd like to speak to you about breathing problems in children under 5 specifically. And I hope by the end of today's session, you will be able to recognize and differentiate between acute and chronic breathing problems in preschool-aged children, so those children under 5 who are presenting outside of hospital or in primary care. You should feel confident in instigating appropriate initial management for these conditions. And if your roles dictate, you should hopefully also feel happy with being able to refer certain children to the pediatric specialist team when they need to. So I'd like to start by covering acute breathing problems. So those breathing problems that present in children quickly, they need immediate attention and may actually need to be seen in hospital. So I always like to divide breathing problems in children into problems of the upper respiratory tract, that is of the nasal cavity, the pharynx or back of the throat, and the larynx, and the lower respiratory tract, which is essentially the trachea, the bronchus, the smaller bronchioles, and the actual lung tissue. And I very much like to take an ABC approach to assessing and treating children with any type of illness, really. And so many of you may be very familiar with this approach. Just to very quickly recap, so A is for airway. You want to firstly ascertain whether the airway is patent, and that can be done quite easily. If the child is alert and they're crying, you don't have a problem. But then you want to hear for any noises that might indicate a partially obstructed airway, like a stridor. B is for breathing, and I will go through this in a bit more detail in the following slide, but for children, it's you very much have to assess their work of breathing. This is something that's very, very peculiar to young children, this term called work of breathing. C for circulation, you want to look for whether there is any impairment in the circulation of a child as a result of their illness. So you obviously want to listen to their heart rate, see if they're tachypneic or if their heart rate is too low. You want to really get your hands on them, feel the temperature of their peripheries. You want to look at the color of their skin to see if they're pale or mottled. And you also want to feel their pulses to see if they're weak or very thready. And I often like to test a central capillary refill time, always done by pressing in the middle of the chest rather than on the fingers, to look at the speed with which the blood returns to the surface of the skin. And that's quite helpful in the context of all of these other signs. Blood pressure is an important parameter to note in young children, but bear in mind that blood pressure can remain normal in a child right until they're about to collapse. So it's not something you should rely on if it's normal. Then we've got D for disability, which essentially covers their consciousness level. If children are unwell, they can appear lethargic or floppy. That's a very pediatric term. But if you can, you try and assess their consciousness level using the GCS or the AFPU score, which is whether the child is alert, responds to voice, responds to pain, or is unresponsive. And obviously, if they're unresponsive, you'll need to go back to A to make sure that their airway is protected. And finally, I like to have an E for exposure, at which point I check the child's temperature and I look at their skin to see if there's any rashes or any other marks or injuries. That's just my little system. So hopefully you'll be quite familiar with this, depending on where you work. So I said I'd go through work of breathing in a little bit more detail before we actually launch into the different conditions, because you're going to be coming back to these signs every time you see a child with breathing difficulties. And I like to have a kind of head down approach. This is the best way I remember these signs, because there can be quite a lot of them. So the first thing you want to assess is something called head bobbing. And this is essentially quite evident in young infants, usually less than 6 months, because their truncal tone and their accessory muscles aren't fully developed yet. And when young children are having difficulty breathing, you'd literally see their head bobbing up and down. So that's what's called head bobbing. You might see something called nasal flare. Again, this is a sign in younger children and infants under 1, where you actually see their nostrils becoming bigger and smaller. And obviously you might note central cyanosis where the tongue might look a bit bluish. And when you see central cyanosis, that usually indicates that the oxygen saturation of a child is less than about 85%. So very important sign, especially if you don't have any means to actually check the oxygen saturations of a young child. Then the next sounds you really want to listen for are stridor, as I mentioned before, which is a sound of a partially obstructed upper airway, and something called grunting. Now, I'll demonstrate the difference, I don't mind, because it is quite important that you are aware. So stridor is an inspiratory noise against a partially obstructed airway, and it sounds a bit like this. So you can see the child is really struggling. It's very upper airway noise, whereas a grunt is something you'll hear again in younger children, possibly early toddlers, and it's a forced expiration against a closed glottis. So it sounds like this. Usually the child is also struggling, and essentially the reason young children grunt is because they might have a lung pathology, which means that the smaller airways within their lungs collapse down when they're breathing. And this grunting actually generates their own end expiratory pressure to keep those little airways open. So if you hear a child grunting, that's definitely a big alarm bell, and you need to act quickly. Tracheal tug is another sign that you may well see. A bit difficult in small babies because of the fact they've got quite chubby faces, not much neck. But if you have an older child, you might see them dipping in just where their trachea is, and that's called tracheal tug. And then you have what's called recessions, sometimes known as retractions or indrawing, and that can happen at various points within the chest wall. So you might get subcostal recession, which is recession under the ribs, intercostal recession between the ribs, and sternal recession, particularly in young babies who have very compliant chest walls, very elastic chest walls. You might see their sternum dipping in and out. And again, these are all signs that the child is really laboring with their breathing. Some children might have abdominal breathing where their abdomen goes up when their chest goes down, and they have this seesaw pattern in their breathing. And never forget to count the respiratory rate. And remember that the respiratory rate does differ according to the age of the child. So in infants up to the age of a year, we do accept a respiratory rate of up to 60, as long as they're looking well with it. And then above that age, anything kind of over 60 really is over 50, sorry, really is abnormal in a child of 1 and above. Great, so I hope that's helpful just to get a little system in your head. So what I'd like to go through now are the actual acute conditions, and we're going to start with croup, which I'm sure some of you will be very familiar with. Also known as acute laryngotracheobronchitis. And as you can see, it's essentially a disease of the upper airway, leading to swelling of the larynx and the subglottic region. So croup is very common in the winter months, caused by common cold viruses such as RSV, parainfluenza, influenza. Obviously, given the last year and a bit of pandemic and COVID, we may well have seen a shift at the timing of our winter viruses at certain times of the year, but certainly croup is classically a winter viral illness. There is a fairly specific age range. It tends to occur between the ages of 6 months to 6 years. And the reason why that's important is because if a child presents with a so-called croup outside of those age ranges, you just need to think a little bit more carefully as to whether something else might be going on, such as an anatomical abnormality. Always think of foreign body in these situations, given, depending on the history. So just think a little outside the box, particularly if it's outside of that age range. But croup is usually a mild self-limiting illness, and very rarely do children become very severely unwell. How does croup present? Well, generally there's a typical prodrome of between 12 and 48 hours of a mild coryzal illness. So children might have a runny nose, they might have a mild cough. But then this can quickly develop into what's known as a barking cough, a hoarse voice, and very typically this stride or this inspired noise against a partially obstructed airway, which then leads to the difficulty in breathing. And classically, these symptoms are worse at night. So oftentimes, if you're in out of hours GP or in A&E, these children tend to pitch up late at night, really. So I want to show you a little video of a child with croup, and I want you to really listen to the noises and just think back to your ABC assessment and really think about those areas where the child is showing signs of increased work of breathing. I'm going to have to come out of my presentation and unshare this screen, so you bear with me just for a second. Lovely, thank you. So I'm going to start playing it now, and this at the start you'll hear the typical barking cough. I'm going to speed it up now to the point where this child, you can probably hear the strider a bit better. Think about signs of increased work of breathing. You clearly hear strider, but this child actually has a biphasic strider. It's quite severe croup. If you see closely, you can see subcostal recession, some sternal recession, and the fact that this child just looks very lethargic, very, very tired and flopped out. There's some abdominal breathing there as well. Okay, I'm going to go back to my presentation now. So yeah, he's a poor little fella. I know he looks pretty wiped out, bless him. So there is quite a convenient Wesley croup score that you can use if you're less familiar with croup, and this is widely available. There's a little reference in that bottom left-hand corner, and this really can help to give you an idea of the severity of the illness that's in front of you. So the bottom line is, if the child has stridor the whole time and is working hard and looks unwell, then really they are severe. If you're able to measure their oxygen saturations, then that's a real bonus. But often you'll find that these children don't want to be handled, they don't want to be examined, and it can be a bit of a battle actually getting quite close to them. So, you know, really use your eyes when you're examining these children. You know, really look at their work of breathing, listen to the noises that they're making, and just really look at them as a whole. So treatment-wise, we generally discourage examination of the throat, because in severe croup, particularly, this can precipitate a complete airway obstruction, and that's the last thing you want, really. But really examining a child's throat normally does lead to a lot of distress, lead to a lot of fighting, and any unnecessary painful procedure like blood tests or IV lines, don't do them if the child doesn't need them, because if a child does get very distressed, it can worsen that stridor and it can worsen that airway obstruction. If you have it to hand, first line treatment in the UK is oral dexamethasone, which is a steroid, at a dose of 0.15 milligrams per kilogram. This is in the BNF, and it's also in the NICE clinical knowledge guidelines here as well. If you don't have access to dexamethasone, you can give a dose of prednisolone, 1 milligram per kilogram, which can have similar efficacy, but depending on what papers you read, you know, it may not prevent recurrence of croup. It might take a little bit longer to work, but actually prednisolone is a perfectly acceptable alternative. If you have a child that is unable to take oral medication because they're so unwell or because they're coughing a lot and they're vomiting, then if you have access to something called nebulized budesonide, then you can give a 2 milligram ampule of that. And that is also a type of corticosteroid that does help and has a similar kind of length of action as Dex. So usually is effective in a couple of hours. If the child is very unwell, if they're very severe, if they're hypoxic, if they're lethargic, then really go straight to an adrenaline nebulizer. You don't need to wait for the dexamethasone to work. And the thing to bear in mind with an adrenaline nebulizer is that they work quickly, but they wear off quickly. And if you are needing to give a child an adrenaline neb, really you want to stay with them. You probably want to get extra help in the form of your pediatric team, anesthetic team, ENT team, really just to be at hand. Obviously, if you see them outside of hospital, if they're having ongoing stridor despite the steroid, then get them across to hospital and make sure you give the dex before they get transferred to hospital so that it at least starts working by the time they arrive. So that's croup, very common in the winter months. You'll probably be seeing it loads now if you haven't already. So the next kind of entity that I'm going to talk about is WHEEZE, and it's quite an extensive topic. And WHEEZE is a disease of the lower airways. WHEEZE can present in children under the age of 1, and we call it bronchiolitis. Between the ages of 1 and 5, where we call it viral-induced wheeze because the pathophysiology is slightly different, and then above 5 years, where we call it asthma as an entity. And for the purposes of this presentation, I'm going to be covering bronchiolitis and viral-induced wheeze. I'm not going to be talking about asthma because that's quite an extensive topic in itself. So we'll talk a little bit about viral-induced wheeze now. So wheeze is essentially a whistling sound that occurs as a result of bronchospasm or tightening of the small airways in the lung. It tends to be prominent when children are breathing out, but you can hear it when they're breathing in as well. And it can be audible wheeze where you just hear it sitting next to the child, or you may need a stethoscope to actually listen to it. It's caused by a variety of things such as infection, inflammation, allergy, as you're aware of, particularly within anaphylaxis, and excessive secretions, which is what we see in young babies with bronchiolitis. For the purposes of viral-induced wheeze, this tends to occur in preschool-age children between the ages of 1 and 5. Typically, it starts with a cold-like symptoms, runny nose, runny eyes, and then is usually followed can be quite quick, sometimes in a matter of hours, by cough, wheeziness, and an increased work of breathing, where children breathe faster, they labor more, and they have the signs that you've seen earlier on. Younger children may not want to feed, and they may vomit when they cough. That's very, very common with young children. I'm going to show you another little video, and again, I want you to just think about your examination findings and the signs of work of breathing when you see this child.
Let's look and listen again.
So hopefully you can see this. Our young child here. Hear the wheeze, and you can see them having subcostal recession. Like if they lifted their chin, you'd probably be able to see some tracheal tug as well. So hopefully you managed to see some of that video with that child wheezing. Apologize if there was a bit of a stop there. So moving on. So essentially treating children with this kind of wheeze. So if you're able to, really, one of the key things to do is to check the oxygen saturations of this child. Essentially, if they have oxygen saturations below 92%, you need to give them oxygen really to kind of maintain their oxygen saturations properly. You then want to give them bronchodilators. So salbutamol is a beta-2 agonist, and you want to give them these bronchodilators via this device, which is called a spacer. And the reason why we give that to younger children is because, firstly, younger kids are not very good at coordinating the kind of breathing technique with just with an MDI, a metered dose inhaler, as it is here. And secondly, what the spacer does is it disperses the particles of the salbutamol into a larger area, so children are just able to use that mouthpiece and they can essentially breathe in and out much more easily. And if you're accustomed to using salbutamol in your practice, then you'll know that children can safely be given between 6 and 10 puffs of salbutamol every 1 to 4 hours. Some children who are known to be wheezers may well have this at home, so their parents may have started giving it to them. And if the child is needing more than 10 puffs every hour, they certainly do need to be seen in hospital. There's also another bronchodilator called ipratropium bromide, which you can give every 20 minutes for the first hour. Also, that's known as Atrovent, and we tend to use that more in hospital. Children who have had recurrent bouts of wheeze often benefit from a dose of oral steroid, which is prednisolone that we give here, between 1 and 2 milligrams per kilogram. So we essentially calculate everything according to weight for children, up to a maximum of 30 milligrams in kids under 5. Make sure that they are well hydrated. So if they aren't able to drink fluids, they may need to go into hospital for nasogastric fluids or even IV fluids. But don't use antibiotics routinely unless there's obvious signs of superadded bacterial infection, so high temperatures, if the child looks less well and they're not feeding. But obviously, as I said, admit these children to hospital, send them to hospital if they're hypoxic, so if their oxygen saturations are low or if they're looking cyanotic, and or they have very severe work of breathing like that child in the video had. So the next entity of wheeze that I want to cover is bronchiolitis, which tends to present, as you can see, in little babies like this one. Usually diagnosed in this country, certainly in children under the age of 12 months, but depending on where you go, that line can shift a little bit. The peak incidence of bronchiolitis tends to be between 3 and 6 months of age, but generally infants born prematurely and with chronic lung disease are at a much higher risk of getting bronchiolitis early. Like croup and viral-induced wheeze, bronchiolitis is caused by your common cold viruses, and there can be some particularly nasty versions of it with viruses like adenovirus and HMPV, which is human metapneumovirus. I don't think I've seen a COVID-19 bronchiolitis, but I have seen a seasonal coronavirus bronchiolitis previously. And what tends to happen is that the infant usually has a school-aged sibling that brings a cold back from school or nursery, and it's often transmitted by them. So it's always worth asking in the family history whether there's a sibling at home. So typically, like a lot of these illnesses we've already discussed, bronchiolitis tends to present with initial coryzal symptoms, so runny nose, sneezing, and is then followed by a chesty cough after about 24 to 48 hours. Babies often do have increased work of breathing with the signs that we mentioned earlier, head bobbing, nasal flaring. And often this comes with reduced feeding because infants are obligate nasal breathers, meaning that they have to breathe through their nose. Feeding and breathing at the same time is a bit too much for them to coordinate, which is why they cannot necessarily finish a feed and they often vomit. In very young infants or infants that are premature, if they have bronchiolitis, they might have apneas where they have pauses in their breathing, or they might have episodes of cyanosis. And in unimmunized infants, so those less than 2 months, always consider whooping cough as a differential in any infant that's having an apneic episode or a cyanotic episode with coughing as well. And typically, the natural history of the disease means that day 3 is often the peak of the illness, and children tend to get worse around the kind of day 3 to 5 mark before they get better. And from day 5 onwards, they gradually improve, and then the whole illness tends to resolve by about days 10 to 14. But a lot of children can get a post-bronchiolitic cough that can last for up to 4 weeks afterwards. And that's important to know, because if the child is well and if they're feeding and they're not having fevers, then nothing needs to be done about this. So when you're assessing the child, obviously use your ABC assessment, but really when you're looking at the work of breathing, count the respiratory rate. Is it greater than 60? That's a red flag. And if you're able to try and measure their oxygen saturations, and if it's less than 92%, then that is certainly an indicator that they do need support. And as we mentioned, the signs of respiratory distress, some or all may be present. You certainly need to assess feeding and hydration status. Typical rule of thumb that we use in pediatrics is whether the child is able to take at least half of their normal volume feeds. Now, if they're bottle fed, you can calculate that fairly easily. If they're breastfed, that's a little trickier, but you can ask the mother how many feeds they've had in the day, how long they're latching on for, and whether they're having any vomits. And frequency of wet nappies is also a key indicator of hydration. So do ask about wet nappies as well in that situation. Treatment for bronchiolitis is supportive. Obviously, as I mentioned, if there's signs of significant respiratory compromise, then you do need to refer to the pediatric team in hospital for support, either with high flow oxygen. If they're really struggling, they might need CPAP. And if they're not able to feed orally, then they might need nasogastric tube feeds or even intravenous fluids in some situations, particularly if they're needing a high degree of respiratory support. However, if the child is a little bit more robust and they have mild symptoms, not needing any other support, then one of the best things to advise the parent is to give them smaller, more frequent feeds. For example, if your child is having 8 ounces every 3 hours, and that's filling up their stomach, squashing up their lungs a little bit and making it difficult for them to breathe. That happens if we have a big pizza on a Friday night and we have to sit back and we can't breathe very well. But essentially, if a big volume feed is making a child more breathless, then advise the parents to give them 4 ounces every hour and a half, or even 2 or 3, at least 2/3 of their normal feed volume if they can manage it. And again, do warn the parents that day 3 of their illness, they tend to get a little bit worse before they get better. Don't give them antibiotics. Unless they're unwell or have signs of a bacterial infection, but bronchiolitis does not respond to antibiotics. And it just leads to antibiotic resistance. So don't treat them with antibiotics. And really going through the natural history of the illness with the parents is very helpful, because then that will help them to understand how their child is looking at certain points in their illness, and certainly will help to reassure the parents when the child is getting better. And we have some very thorough, very well written, nice guidelines on bronchiolitis if you need to refer to those at any point. So they're really worth a look at if you need a bit of a refresh. So the final acute issue that I'm going to touch on is community-acquired pneumonia, and this is a nice X-ray of a right-sided consolidation there. So essentially, pneumonia is infection of the lower respiratory tract and the lung tissue, which leads to this consolidation or this solid area of lung. And it can happen to any child, but there are certain groups of children who are at higher risk. Again, babies born prematurely who may have chronic lung disease, so they may still require oxygen. Children with cystic fibrosis, children with congenital heart disease, which is not that common. Kids with tracheostomies, which need regular review, and those with neuromuscular disorders that may not have the efficacy of breathing and the ability to clear secretions. So those groups of kids are particularly vulnerable. Now, pneumonia is caused by a variety of illnesses, but interestingly, up to 1/3 can be viral in nature, but it is difficult to distinguish this clinically sometimes, really, because kids can still have high fevers and look unwell. Common bacterial pathogens include Streptococcus pneumoniae, which is most likely in children under 5, Staphylococcus aureus, which can lead to cavitating lesions, and Mycoplasma pneumoniae, and that tends to be in children over 5, and that's often referred to as an atypical infection. Usually presents with a high fever, greater than 38.5. And I've just put a note of greater than 38 in children less than 3 months, because in infants younger than 3 months, we have a slightly lower threshold for fever and needing investigation. Usually presents with cough and dyspnea or shortness of breath, difficulty in breathing. Some children might complain of pleuritic chest pain, so pain when they're breathing in. But interestingly, certainly in the pediatric group, some children might complain of upper quadrant abdominal pain. So bear that in mind if you don't find any obvious chest signs, but if children are complaining of right upper quadrant or left upper quadrant pain, along with cough and fever. And kids do often vomit because young children are not very good at coughing up phlegm. Younger children usually swallow this, and if they keep swallowing their sputum, it makes them feel unwell and it leads to vomiting. So that can be a sign as well. Very non-specific, but something to bear in mind. So again, when you're assessing a child, part of your ABC assessment, you're going to be fed up of me saying this, always count the respiratory rate, bearing in mind the age of the child, and again, check the oxygen saturations as well. And depending on the age of your child, a child who is looking or behaving agitated or with a depressed consciousness level, if they're lethargic, may be a sign of hypoxia if you're not able to measure their oxygen saturations. If you're able to percuss their chest to find any signs of dullness, and obviously listen to their chest for any localized signs, any crackles or crepitations. And wheeze can sometimes be there as part of an atypical infection and may not respond to bronchodilators. And look at their general status as usual, their hydration status, whether they're lethargic. And as always, if the child is acutely unwell with the red flag signs that we've talked about, kind of high respiratory rate, grunting, cyanosis, then refer to the pediatric team in hospital straight away. However, if you have a child that isn't that unwell, then the first line treatment for us here in the UK is oral amoxicillin for up to 7 days. There are alternatives in the form of co-amoxiclav, but we're less keen on giving that because of resistance developing. And you can use macrolides as well, such as clarithromycin or azithromycin for atypical infection or for penicillin allergy. We've moved away from giving erythromycin because A, it causes children to vomit a lot, and B, it needs to be given 4 times a day, which is often a bit of a struggle for parents of very young children. Give antipyretics such as paracetamol just to bring temperatures down. If they're not eating very much or not passing much urine, I'd probably steer away from ibuprofen because of the gastric irritation. And obviously encourage regular fluids or breastfeeds if the child is young enough to breastfeed. It's always good to safety net in this situation. So do tell the parents what signs to look out for if the child is deteriorating. So if they appear to have an increased effort in their breathing or are breathing quicker, if they're eating and drinking less or they're more lethargic, then do ask the parents to seek medical attention again. It's always prudent to review the child if you're in primary care after 48 hours if their fever doesn't settle, because in the context of a pneumonia, if they have ongoing fevers, then they might be at risk of developing an empyema or pus within the pleuritic space. Gosh, I'm going to take a quick drink of water before we launch into chronic breathing problems. I think I'm doing okay for time, Andrew.
Yes, absolutely. And the good news is we've got the amazing fast internet connection back.
Great. Okay. I hope that's true for me. I just got a sign saying my internet connection is unstable. So I hope you can still hear me all right.
Perfectly.
Great. Okay. Great. So thanks for bearing with me this far. We're going to now move on to chronic breathing problems and how to tackle those. So I'm going to cover broadly 2 areas. So one is snoring and causes of snoring, which is generally an upper respiratory tract issue. And then the issue of chronic cough and just reviewing pathologies coming from the lower respiratory tract. So snoring, first of all. seems fairly benign, but it can become problematic if a child's snoring is loud, if it's persistent, and if it's associated with periods of ineffective breathing, meaning periods of gasping or pausing for 15 seconds or more. And the key points in the history that you want to ask parents about, really, because a child wouldn't really recall that they're snoring, is firstly, does it occur every night? Secondly, can a parent hear them from a different room? Which sounds funny, but actually, you know, that is an important differentiating factor in the history. Are there any associated choking, gasping, or pauses in the breathing for more than 10 seconds? And does a child complain of any unusual symptoms the following day, like any headaches or feeling very tired, which may well indicate that they've not slept well? And with children, school performance is a very sensitive indicator of any problems within their health. So has there been any changes in their learning or in their behavior as well as a result of this persistent problematic snoring? There are a wide range of differentials for snoring, as you can see in this table. I'm not going to go through every single one of them in detail, but suffice to say the most common cause of snoring is obstructive sleep apnea. And that's caused generally by the two highlighted conditions above, which is adenotonsillar hypertrophy and allergic rhinitis. So it's by far the most common cause of snoring. Obviously, think about any anatomical problems, or if the child in front of you looks dysmorphic, then they might have a syndrome associated with a small lower jaw or a large tongue, like Pierre-Robin sequence. And obviously, think of any central causes like cerebral palsy or seizures that might lead to snoring and ineffective breathing at night. Quick picture of your adenoids and your tonsils. So your adenoids are the pads of tissue at the back of your soft palate, as you can see there. And if they're enlarged, then they tend to obscure the eustachian tube. And your tonsils are again at the back of the pharynx. And if they're very enlarged and inflamed, they might even be what's called kissing tonsils, so touching in the middle, and that can certainly lead to problems in snoring and upper airway noises. Might lead to mouth breathing as well for certain children. So general principles of management if you're seeing a child with snoring out of hospital is, first of all, to document their tonsillar size, actually have a look at the tonsils. If the child is overweight or obese, this could be a factor as well. So not easy to do, but certainly addressing weight in the context of obesity and obstructive sleep apnea is key. It might be worth doing a chest X-ray to rule out any lower respiratory tract pathology if there's no obvious tonsillar enlargement. But if there is, and if there's any hint of adenoidal hypertrophy, then intranasal steroids for up to 8 weeks in mild or moderate symptoms might make some difference. Children to refer are those who really do have signs of obstructed sleep disordered breathing, just as we discussed. And in this case, a referral to ENT for consideration of a sleep study and possible adenotonsillectomy would be very justified. Pediatric ENT teams are generally very helpful and very, very happy to kind of see children for this. Obviously, if the child you're seeing has suspected severe sleep apnea, then they'll need a more urgent specialist assessment depending on where you are. And I'll touch on tonsillitis because this is exceedingly common as a presentation as well in primary care. Often see this in children above 3 years of age, but a lot of preschool children do come in with sore throats. We have now reverted to making a clinical diagnosis of tonsillitis rather than taking throat swabs. And some of you may already be familiar with this, but we are now using what's called the fever pain score for diagnosing tonsillitis. So it's essentially 5 points. Fever in the last 24 hours, fever being a temperature of over 38, purulence or pus on the tonsils, whether the child presents quite quickly because of the discomfort within 3 days of onset. I is for severely inflamed, tonsils very red, and no cough or coryza, so definite lack of any obvious viral kind of coryzal illness beforehand. Now, bear in mind that pus or exudate on the tonsils does not automatically make it bacterial. You can certainly see exudate in viral tonsillitis. So a little disclaimer there. But essentially, with the fever pain score, each parameter is 1 point. So that will dictate your score essentially. So treatment-wise, if it's viral, which again, may well be indicated by how the child presents or by your fever pain score, you can treat them symptomatically. So pain relief, paracetamol, ibuprofen, throat spray, if the child is able to take it, like Difflam, plenty of fluids, that's the best way to go. But if your fever pain score is 4 or 5, then there's a much higher likelihood of isolating a streptococcal illness. And in this case, penicillin V is indicated for treatment, and you can go ahead and start that. But do counsel the parents that antibiotics don't necessarily prevent recurrence of tonsillitis. And the most recent guidance from the ENT kind of bodies has been that criteria for surgery essentially is 7 or more episodes of tonsillitis in 12 months, or 5 or more per year in each of the preceding 2 years, or any complications such as quinsy. So that's certainly something to bear in mind. And obviously, if the child is having problems with obstructive sleep apnea due to chronically enlarged tonsils. And that's from a recently published commissioning guide on tonsillectomy, which you can access very easily on the internet. I want to just quickly go over allergic rhinitis, because again, I suspect this is something that presents fairly frequently in primary care. It's very common. About 20% of the population as a whole can have this. And again, key questions in the history, just to really hone down on things, is asking about seasonality. Does it tend to occur in spring and summer, or just one or the other? It depends on whether it's grass pollen or tree pollen that's coming out. And you want to ask for any environmental exposures like parental smoking, the presence of any pets, or then potential dust mites as well. And when you examine these children, they might be mouth breathing, they might be rubbing their nose, they might have red watery eyes, and they might have a nocturnal cough, which may well be an indicator of postnasal drip. They might have other signs of atopy as well, such as eczema. Investigations, you don't often need to investigate these children if they have very obvious symptoms, but if there's any query in their symptomology, then you could request specific serum IgEs to, for example, dust mites, or to cat hair or dog hair. And potentially skin prick testing, but you really need to know what you're testing for. We don't tend to do just panels of general tests because it's not very helpful. And these children will need referral to allergy clinics if you are going down that route. And treatment, obvious things such as allergen avoidance, if possible. If not, then antihistamines such as cetirizine are very effective. It's non-drowsy. Or chlorphenamine, Piriton can be given before bed, and intranasal steroids can be helpful if there's any evidence of any nasal polyps. And referral to an allergy specialist or to a respiratory specialist is entirely justified if symptoms are difficult to control. So finally, chronic cough. So again, something we see quite frequently. I want to just go through a few definitions so that we're all clear on what we mean by chronic cough. So a chronic cough, we would call a non-resolving daily cough that lasts longer than 4 to 8 weeks. A little bit vague, but essentially if a child is coughing every day for more than 4 weeks, they can certainly fall into that category. Now, a recurrent cough is a little bit different in that this is where a child has 2 or more cough episodes per year, and each episode lasts more than 14 days. Slight variation on the chronic cough is the prolonged acute cough, where a child has a cough lasting at least 3 weeks, which might be getting worse and may need early investigations. And the simplest definition is your acute cough, which is a recent onset cough lasting less than 3 weeks. But really, try and get the chronic cough definition into your head as the most useful one here. But bearing in mind that preschool age children can have an average of 6 to 10 respiratory infections per year, particularly if they're in nursery and preschool. Again, we've seen a slight change in that number in the last year, 18 months with the pandemic. But certainly kids pick up a lot of respiratory infections normally, and that doesn't necessarily mean that they're immunocompromised or have any problems with their lungs. So key points in the history to ask with these for these children are, first of all, whether the cough is productive of sputum or wet sounding, or if it's non-productive or dry. Again, bearing in mind that young children often swallow their sputum, they don't cough it up, but it's really what the cough sounds like. Ask the parents whether there's any trigger to the child's cough. Can it happen after exercising, which might indicate a more asthma-like component to it, or can it happen after eating, which could indicate a more reflux type component? Does the child have any associated symptoms, such as shortness of breath or chest pain, or hemoptysis, which is obviously a very worrying sign? And ask about any relevant past medical or birth history. For example, if the baby was born prematurely, were they intubated? Because that could lead to a subglottic stenosis that we're not aware of. They might have chronic lung disease, having been dependent on oxygen for a while. Or there might be a history of atopy. For example, if the child had cow's milk protein allergy as a baby or eczema, then we know that these things are associated with a higher likelihood of developing atopic asthma later on. Most importantly, do ask whether there are any smokers at home, because passive smoking is a huge trigger to chronic cough. Red flags to look out for, and I hope these will be quite obvious to you all, include weight loss or diarrhea, which could indicate a degree of malabsorption. Recurrent severe infections of the ear, nose, and throat or chest, which could indicate immunocompromise, or apneas in young babies, which could indicate whooping cough, particularly if they're unimmunized. Lots of differentials of chronic cough, which I am not going to go through in the last 10 or so minutes of this presentation, but really do try and think about it as systematically as you can, dividing it into upper airway, lower airway, lung tissue disease, and central causes. Don't forget foreign body, even in chronic cough. You'll be surprised. You just really need to delve into the history, because sometimes there can be a lodged foreign body, such as a peanut, that causes inflammation and can lead to chronic cough. And I've underlined protracted bacterial bronchitis, which is essentially another way of saying a kind of long-term infection that's now being seen more commonly as an entity in young children. But age of onset is really important. So always bear in mind how old the child is when you're asking your history and when you're considering your differentials as well. So initial investigations, if you're not in the hospital, this is not really an investigation, but really all children, you should try and plot their weight and their height to make sure that they're thriving and they're growing. If there is a worrying pathological process going on, then you will see that that's definitely affecting their growth. If the child is close to 5 years of age and they're compliant, you can try to do a peak expiratory flow rate. And if it's less than 80% of their height, think of an evolving asthma type picture. A chest X-ray is always helpful in chronic cough. You can see a variety of things, not just within the lung tissue. You can see any anatomical abnormalities of the airways and of the structures around. And taking bloods for infection markers, signs of chronic anemia, eosinophils for any allergic component, and serology, for example, of mycoplasma is always helpful. And when to refer these children. So obviously, if you have signs of, poor growth or nutritional compromise as a result of malabsorption, then this could be a sign of cystic fibrosis, and these children certainly do need to be referred. If the cough persists despite any treatment or interventions, And with preschool wheezers, so the viral induced category, children who are having frequent exacerbations leading to hospital admissions may well require a little bit more intervention. And obviously, if you have any abnormalities in your investigations, that would certainly be a good reason to refer. Parental anxiety without evidence of any underlying pathology really shouldn't be a reason to refer. You should be able to, I hope, reassure parents with your examination and investigations that you've done to allow watchful waiting. We don't often encourage or recommend any cough medication over the counter. They don't do anything at all. And obviously, if there is evidence of any family member smoking or any exposure to cigarette smoke, then giving smoking cessation advice to parents is often very helpful. If you're in the position where you've referred a child with chronic cough and you're awaiting for them to be seen, obviously this can be a source of anxiety while waiting. So things to do while you're waiting would be to chase the results of any investigations and update the referral if necessary. And obviously, depending on the likely diagnosis, you can certainly start treatment according to your NICE guidelines, British Thoracic Society guidelines. For example, if you have a child with a dry cough with some evidence of atopy, you can trial them on inhaled steroid via spacer. If you have a child that's got a chronic productive or wet cough, then that may well be a protracted bacterial bronchitis, and you can try them with a 2-week course of a broad spectrum antibiotic like amoxicillin or coamoxiclav. So there are options. Always keep the child, if relevant, and parents updated with what's going on. And you can always ask for advice from your local paediatric team via telephone or email while you're waiting if needs be. So that's the end of my presentation. So in summary, I hope that you'll now be able to recognize and differentiate between acute and chronic breathing problems in children under 5 presenting to primary care or outside of hospital. I hope you'll feel more confident in instigating appropriate management and assessing children using the ABC technique. Know when to refer to secondary care or to hospital. And that's it. Thank you very much.